So good afternoon, everyone. My name is Dan Ohlendorf. I'm ICER's Chief Scientific Officer. I hope those of you that were here this morning had a great lunch and you're ready for an interesting afternoon to discuss inotersen and patisiran for hereditary transthyretin amyloidosis. So there was a more involved conversation this morning about why we're here today and the sort of workings of ICER as an organization. I won't go through the organizational details as much, but I think it certainly is a good idea to set some context around this. So I want to read two quotes to you. One comes from the Amyloidosis Research Consortium. The prospect of new treatments designed for slowing and stabilizing hATTR offers significant hope to patients and their families. This is especially so given the context of the disease being hereditary, the negative impact it has on patients and carers' quality of life, and there being no other licensed alternatives available with which to treat the disease. We also have a quote from a patient. We received many patient comments throughout our project process, many of them initially, but also throughout the production of the draft report and the revised report. So from one patient, working for a private company that is self-insured does not give me unlimited access to funds. We will play this out to whatever our insurance carrier can provide and see what is left. If my portion becomes an amount that starts eroding my ability to care for my family, I will have no choice but to discontinue and eventually enter palliative care. My life insurance, along with other provisions I have made, will hopefully carry them to the end of their natural life. So this is a realm in which we often find ourselves as an organization. We're looking at the prospect of exciting and innovative new treatments. We also have an affordability challenge both at the level of the individual patient and as a health system, and we have to examine those trade-offs carefully, and that's really what this afternoon's about. So, increasing healthcare costs affect individuals, state, and federal budgets, as I just mentioned. New treatments, especially those for ultra-rare conditions such as this one, often raise questions about long-term efficacy and safety, as well as appropriate use and affordability. Patients can have difficulty accessing drugs through either high out-of-pocket costs and or limited access to treatment centers, centers of excellence, and clinical experts. And there needs to be an objective evaluation and a public conversation, which is what this is intended to be, on the evidence for effectiveness and value. So how was our report developed for these two agents? So we have an initial scoping process where we allow for open input really from any stakeholder. We also provide our own outreach to some of those stakeholders to try to get that information internalized so that we can come up with the right scope for the project. And so we relied on guidance from patient groups and advocates, clinical experts, some of whom are here today, manufacturers, as well as other stakeholders. In this case, the internal research team at ICER conducted this analysis along with expertise from Dr. Karen Lasser at Boston Medical Center, who will be presenting evidence, the review of the clinical evidence, as well as Dr. Jeffrey Hotch from the University of California, Davis for the cost-effectiveness modeling. We also have opportunities for public comment. I mentioned the open input. There's also a formal public comment period during the scoping phase, and another formal public comment period during the posting of the draft report. And we revised based on those comments. And we had a variety of expert reviewers for the evidence report, both on the clinical evidence side and the modeling, including Dr. Merrill Benson from the Indiana University School of Medicine, Dr. John Burke, who was gracious enough to work with us today from Boston Medical Center, Dr. Rita Faria from the University of York, Sarah Richard from the Amyloidosis Research Consortium, and Dr. Rick Ruberg, also from Boston Medical Center. So it's important to recognize that none of the expert reviewers should be considered to have endorsed the report in any way, shape, or form. They simply provided us guidance and input that allowed us to inform our revision. And in terms of ICER's general approach, how do we structure our evidence reports to support your voting and policy discussion as a panel? So we have what we term a value framework, with the goal being sustainable access to high-value care for all candidate patients. Two elements to this framework. One we call long-term value for money. The other focuses on short-term affordability. On the side of long-term value for money, this is really a compilation of different domains. So this includes our review of the comparative clinical effectiveness of these agents, the interventions of interest, an examination of the incremental cost effectiveness over the long term, which is also a feature of the report. And then there are other benefits and possibly disadvantages of these treatments that are not really well or easily captured in either the available evidence or in the modeling, and some contextual considerations around the introduction of these therapies that should be considered outside of the quantitative framework. And so those are elements that you as a panel will consider as we go through this afternoon. On the short-term affordability side, so this is not an aspect of our long-term value for money domain. This is really trying to understand whether there's a need to signal to the health system that there may be an affordability challenge. Even if the therapies of interest are considered to be of high value, there may still be a challenge in the short term in trying to provide access to all patients. And so we raise that kind of as a separate flag when and where that's available. So we're almost through the opening remarks in the afternoon. In a few minutes, I'll turn this over to Dr. Lasser and Dr. Hotch for the presentation of the evidence and the economic modeling. We'll have some time for public comments from both members of the general public as well as manufacturers. We'll then walk through the Midwest CEPAC votes on effectiveness and value. And then in the last hour or so of the meeting, we will engage in a policy roundtable discussion after all the votes have been taken to try to understand what the policy concerns and issues are and how we, as a group of stakeholders, can try to address them. And then we will adjourn on time at 5 o'clock. And so without further ado, why don't I turn this over to Dr. Lasser.
Is this still on? Good. Well, good afternoon, everyone. My name is Karen Lasser. I'm from Boston Medical Center, and I'm a general internist and researcher, and I'm delighted to present the evidence review this afternoon. But first, I'd like to acknowledge our research team and to report that we have no conflicts of interest to disclose. So let's talk about hereditary transthyretin amyloidosis, or hATTR. So this disease is caused by any one of 130 different gene mutations that cause protein made in the liver to misfold in deposit in the various body organs. These proteins disrupt the function of the major organs. So given the fact that there are so many different mutations and many different organs, there's a lot of heterogeneity in the clinical presentation of this illness. So the age of onset varies and the clinical presentation varies. However, there are two forms of the illness that have been well described in the literature. The first is the cardiac predominant illness, which is most prevalent in the United States and is most predictive of early death because the amyloid deposits in the heart, causing congestive heart failure and arrhythmias. The other predominant form of the illness is the neuropathy predominant illness. This is the most physically disabling, where the proteins are lodging in the peripheral nerves and the autonomic nervous system. This is rare worldwide, with about 10,000 cases worldwide, and in the US, there's estimated between 3,000 and 3,500 cases. So in terms of therapies, did I miss the slide 1 second? Oh no, okay. In terms of therapies for hATTR, until recently, there was no therapy approved in the US. And there are three approaches to treating this condition. The first is to remove the source of the transthyretin protein, and this is done through liver transplant. However, this approach is limited by the morbidity and mortality associated with the procedure and the fact that the disease can progress after transplant because the proteins have already lodged in the organs. The second approach is to stabilize the TTR protein, and this is done through off-label use of diflunisal, which is a non-steroidal anti-inflammatory medication in the same family of ibuprofen that is limited by the side effects of medications in this class, such as GI bleeding and contraindication in renal insufficiency. The third approach is to knock down the TTR levels by interfering with RNA. And as you'll recall, RNA is what encodes the proteins. And so the two therapies we're going to discuss today use this mechanism. The first is inotersen, which is an antisense oligonucleotide, which is administered subcutaneously, and FDA approval for this drug is expected in October of this year. And of note, there are other therapies that have been tested using this mechanism. The second therapy we will discuss is patisiran. This is an RNA interference drug. It's the first of its class, its mechanism. It is administered IV every 3 weeks with a steroid and was approved by the FDA this summer. In the course of writing this report, we received many letters and comments from patients, their caregivers, and advocacy and research organizations such as the Amyloidosis Research Consortium. We heard from these groups that this is a severe disabling illness that profoundly impacts all aspects of quality of life. Patients and their caregivers may be unable to work, unable to have hobbies, and ultimately for patients, they may be confined to their houses due to impairment in their ability to even do the most basic activities of daily living, such as bathing themselves, feeding themselves, and getting dressed. This condition affects multiple members and generations of families. So it's possible that an individual is a caretaker for someone in the older generation who's sick while starting to develop symptoms themselves and then experiencing the emotional burden of worrying about their children and what's to come. Because of the disabling nature of this illness, it can be difficult for patients to travel to centers of excellence to receive treatment. So we heard that new treatments for this condition offer much-needed hope to patients and their families. However, affordability of new therapies is a major concern. The list price for patisiran is $415,000 a year. We heard from patients that they were not willing to bankrupt their families to pay for this therapy. So now I'll get to the scope of the review. So we're going to evaluate the clinical effectiveness of inotersen and patisiran respectively for hATTR. Our goal is not to compare the two therapies because of differences in the trial design, the patient populations that were in the studies, and the outcomes. The comparator for this review is best supportive care. And the outcomes that are listed on this slide, I'll go into in more detail on the subsequent slides. So here's the body of evidence. We have two trials of inotersen, one phase 3 RCT with an open label extension, and one single-arm open label trial. We have two trials of patisiran, one phase 3 trial, one phase 2 trial, and one open label extension. I'll note that the two phase 3 trials were published in the New England Journal of Medicine this summer. We're going to focus on those trials because they had larger sample sizes, and the doses that were studied were for patisiran, the dose that was ultimately approved, and for inotersen, it's the dose that is likely to be approved. Okay, I'm going to use my pointer here. So this slide gives an overview of the randomized trials. Here we have the inotersen trial. It lasted for 15 months. There were 173 patients, mean age 59, 92% white, just under half from the US, and 2/3 were familial amyloid polyneuropathy stage 1, meaning that they were able to ambulate without assistance. This trial had a co-primary outcome. It had the modified neuropathy impairment score +7, which was modified for this trial and is on a 347-point scale. The other co-primary outcome is the Norfolk Quality of Life Diabetic Neuropathy Questionnaire, and this is a patient-reported measure. Now turning to the patisiran trial, it was a little bit longer at 18 months, slightly larger, 225 patients, similar age, 3/4 white, only 20% from the US, and notably only 46% of trial participants could ambulate unassisted, so these patients were sicker. And they had just one primary outcome, the MNIS plus 7, but on a different scale. So an important point to make here is there is not a minimally clinical, there's not a change in the score that represents a validated clinical improvement. I'll say it that way. We can see statistical differences in the changes, but we'll have difficulty saying what the clinical significance is, and I'll get into that more on future slides. So again, our primary clinical outcomes. The MNIS plus 7 is a composite score of motor strength, reflexes, sensation, nerve conduction, and autonomic function. A higher score indicates worse neurologic function. Same thing with the quality of life score. A higher score is worse quality of life. These are the secondary and exploratory outcomes that were in the trials. Modified body mass index is used to measure wasting associated with progression of neuropathy and disability. There are two measures of disease progression, the familial amyloid polyneuropathy stage, which ranges from 1 to 3, going from ambulating without assistance to being wheelchair or bedridden. Similarly, the polyneuropathy disability score is a 0 to 4 scale that has the same range, and a higher score on both of these is worse functional impairment. Then we have the cardiac measures. The N-terminal pro-BNP is a marker of congestive heart failure and has been associated with mortality in this condition. We'll also look at some echocardiographic measures. So now on to the results for inotersen. So using my pointer here, we see this is the primary outcome of the change in the MNIS plus 7. Here we see placebo is getting worse with neuropathy impairment. Inotersen is also getting worse, but it's less worse. And there's a 19.7 point difference here that is statistically significant, but is of unclear clinical significance. We have the same story for the quality of life. Placebo quality of life is getting worse. Inotersen is maybe getting a tiny bit worse or stabilized. There's a statistically significant difference here, but it's unclear clinical significance. In terms of the secondary outcomes, there was no improvement in the inotersen arm with regard to the polyneuropathy disability score, the cardiac measures, or the modified BMI. Now this slide summarizes the harms, and we see inotersen in the right column. We'll see that a greater proportion of inotersen patients had any adverse event leading to drug discontinuation. More had any serious adverse events. There were 5 deaths in the trial, all of which occurred in the inotersen arm, and 1 was felt to be drug-related. 3 cases of glomerulonephritis. 13% of patients had thrombocytopenia, and this is a known side effect associated with drugs in this class. And finally, 30% of patients developed anti-inotersen antibodies, which are of unclear clinical significance. On to patisiran. So here we have the primary outcome again, which is the change in the MNIS plus 7. Placebo is getting worse. Patisiran, we actually see, is getting better. Again, we have a statistically significant difference, unclear, validated, whether this is a clinically significant finding. Same story for quality of life. It's getting worse with placebo. It's getting better with patisiran, and then is kind of stabilizing. This is a statistically significant difference, but unclear clinical significance. In terms of the secondary outcomes, for the modified body mass index, patisiran patients showed improvement relative to placebo. Both measures of progression of disease, the familial amyloid polyneuropathy stage and the PND, were stable or improved relative to placebo. For the cardiac measures, the NT-proBNP was decreased versus placebo. This is of unclear clinical significance. Finally, there were some post hoc analyses in the cardiac subgroup of patients which showed a decrease in the composite measure of all-cause mortality and hospitalizations. Okay, now we get to the patisiran harms. There were more adverse events leading to drug discontinuation in the placebo arm. Any serious adverse events were pretty balanced between the two arms. Deaths were balanced between the two arms. However, it is worth noting that all 7 deaths in the patisiran arm were cardiovascular in etiology. And then there is some new data that came to light actually today that isn't in the evidence report, and that is that there were 3 cases of complete AV heart block with patisiran that required pacemaker. There were no cases of AV heart block in the placebo arm. And then the 2 main side effects with patisiran were peripheral edema and infusion reactions. Yes.
Sorry to interrupt. Just to add a little bit more context to what you just mentioned on the AV block. So that was not in the original label for the product, but that label was revised at the end of August, and now the line about AV block is in there. There's also mention in the FDA review that the cardiovascular deaths appeared to be clustered around worsening heart failure as the reason, but there was not enough information for the FDA to conclude that it was at this point that it was a safety signal worth pursuing. So just to add a little bit more context.
Great, thank you. Okay, so the other harm that we considered was the harm associated with steroid use, and we deemed there to be a low to moderate risk of long-term harm from the steroid administration, but of course this depends on patient characteristics. For example, if a patient had diabetes, and we based this risk estimate on analogous steroid use in other therapeutic areas such as cancer chemotherapy. So there remain a number of controversies and uncertainties. Again, there's unknown clinical significance for the magnitude of changes that were observed in the trials. It's also not yet possible to determine which patients are most likely to respond to treatment. These studies were not powered on cardiac outcomes, and generalizability may be limited in the US. The other thing to note is that loss to follow-up in the inotersen arm was higher, which might overestimate the benefits of inotersen. Finally, long-term safety is unknown. Patisiran is the first RNA interference therapeutic to be approved by the US FDA, so it is possible that new safety concerns will emerge. So here are our evidence ratings. We gave inotersen a C+, given that there was an improvement in the primary outcomes, there was just less worsening, and then there were some safety concerns around all deaths being in the inotersen arm, the thrombocytopenia, and the anti-inotersen antibodies. We gave patisiran a B+ because there was improvement in the primary outcome, but again, there are safety concerns, especially this new cardiac data that has come to light. We heard from patients, caregivers, and advocacy groups that there are potential other benefits and contextual considerations. Patisiran is the first US medication approved to treat this condition, and inotersen may follow. There is an injectable formulation of inotersen, and patients really value the option to have in-home treatment. These new treatments may positively impact caregiver and family burden. However, we don't have evidence on this. These treatments offer much needed hope for affected families, and we now have the potential to increase screening and diagnosis. We received many public comments on the report. We heard from people that they felt that our initial evidence rating of promising but inconclusive for inotersen was too low. We went back and took another look at the evidence and raised the rating. Some outcomes that matter most to patients were not captured in the trials. For example, a patient's ability to attend his grandson's football games. Tafamidis is an important new treatment on the horizon. There was a recent study in the New England Journal of Medicine in cardiac amyloid patients with mortality as the primary outcome. And there are important questions that remain. When should we initiate this therapy, and how long should it continue? So in conclusion, new therapies appear to halt progression or improve neuropathy symptoms and quality of life in hATTR. However, there is uncertainty regarding specific safety issues and long-term safety overall. Studies with primary cardiac endpoints are needed. And finally, affordability is a major concern for patients and their families. I'll stop there. Okay.
Thank you very much. It was an excellent presentation. So we'll open up questions and comments from the panel. But before we do that, if we can go around the table and just confirm that there are no conflicts of interest to declare. Let's just do that quickly. We didn't do it. Okay. Eric Armbrecht of St. Louis, no conflicts.
No conflicts of interest. Timothy Will.
Hi, Stacy Doucette-Zena, no conflicts.
Don Casey, no conflicts.
Aaron Carroll, no conflicts.
Ray Mustafa, no conflict.
Harold Pollack, no conflicts.
Ryan Barker, no conflicts.
Jill Johnson, no conflicts.
Stuart Winston, no conflicts.
Greg Kerfman, no conflicts.
Thank you, everyone. Would anybody like to start us with a question or a comment?
Eric, I also failed to ask our clinical experts and our patient representatives to introduce themselves and also provide any disclosures, so we should probably do that
Do
too.
the same. Great.
Yeah.
And welcome. Thank you for coming today. Would you want to start us out, Joel?
I'm Joel Buxbaum, and I'm Professor Emeritus.
Oh, microphone, sorry. Thank you. Try again.
Sure. I'm Joel Buxbaum. I'm Professor Emeritus in Molecular Medicine at the Scripps Research Institute.
That's fine. You're fine.
And I am a consulting chief medical officer in Misfolding Diagnostics, a small company that's trying to develop diagnostic and prognostic biomarkers for these diseases.
Thank you.
John Burke, Boston University. I've done some small consulting for Alnylam and Ionis.
Thank you.
I'm Kristen Sue from the Amyloidosis Research. I'm Kristen Sue from the Amyloidosis Research Consortium, or ARC. I have no personal conflicts to disclose. ARC does receive external funding from a number of companies in this disease space, but we retain control over any projects for which we're funded.
Thank you, Kristen.
I'm Dustin Carr, patient advocate here today. No personal conflict of interest. I am on inotersen as part of their expanded access, have been for just about 6 weeks.
Great. Thank you. Thanks for being here, Dustin. Okay, friends. Stacy, would you like to kick us off?
Sure.
Thank you very much.
So I guess, considering these two measures, it was a little bit difficult to get a sense. I know you said that there's not an ability to tell the clinically significant difference with the main outcome measures, the quality of life or the NIS. Mm-hmm. I'm just curious, are those obviously seem like they're very important measures in this disease state. Is there some other measure that you think would provide a better clinical marker of how well people are doing?
Yeah, so there's a measure called the NIS +7, where they've shown a 2-point change is clinically significant.
So is there any rationale for the modified version? I mean, the one that doesn't seem to have a validated change?
Maybe I will ask our clinical expert, Dr. Burke, to talk about why the MNIS +7 was used.
So the 2-point change in the NIS +7 is something that a neurologist can detect. And in diabetes, it takes 2 years before you see a 2-point change. In contrast, you're looking here at the year-plus data, and these people are dramatically progressing. So a change of 10 to 20 points is the ability to get out of a chair without using your hands. These people enter a trial with some impairment that a neurologist can detect, and by the end of the trial, they're in placebo, they are completely debilitated.
But I guess the point here is there's no validated, it hasn't been validated how many points you need to change to see a clinical difference. And then we also do have the FAP stage and the PND, which show changes in functional impairment.
So as a non-clinician,
Yeah.
can you, so does that, the measure has not been validated? Is that what you mean?
Yeah, the measure has not been, like in.
Or is it
yeah.
the change in the measure?
Yeah, the change in the measure has not been valid. Hasn't shown a minimally clinical important difference.
So the score difference is statistically significant,
Yes.
but we don't know.
We don't have it hasn't been validated that a 19-point difference leads to clinical improvement.
But that is related to the measure, not necessarily the drug.
It's the measure.
Okay.
It's the measure.
Thank you.
Reem, please.
A couple points, just to kind of follow up on that. I understand the limitation of that change not being validated,
Yeah.
but do we think from the patient perspective, do we think that's clinically meaningful, is the question. Even if it's not validated, but do we think that's a clinically important difference?
Well, I think for patisiran, we are seeing improvements in all of the secondary measures, which include the FAP and the PND. So that's suggestive that these are clinically meaningful.
One quick comment about the FAP and PND scores. These are very general categories, and you have to have more than profound change to go from one stage to another. And conversely, improvement would be really dramatic. It would be miracle stuff. So that basing your analysis of the effectiveness of this drug or these drugs on a PND score change or an FAP stage change, I think would be misguided.
Okay, and can I have my second
Yeah,
question?
please.
Based on the new data that came to light, do you think that your your judgment about the ICER evidence rating for patisiran would be different? Will it stay B+, or will it move to C+?
We talked about this a little bit, and we decided to keep it at a B+ just because of the evidence of improvement. Also, the deaths were balanced between the two arms, but it is a concern moving forward, and it may be more of a concern for patients who have concomitant cardiac involvement.
Greg, would you like to ask a question?
I was trained as a cardiologist, so I know more about the cardiac disease than the neurologic disease.
Yeah.
But I couldn't help, and I don't want to get us off track here,
Yeah.
but I couldn't help being very impressed with the recent New England Journal article on tafamidis and the presentation at European Society of Cardiology, with an endpoint of overall mortality going in the right direction. And I just hope that we can have some discussion to provide context about that agent as well. I know it's not part of the evidence report, but it's kind of hard to ignore.
Yeah. And remember, the label for these two medications, they're approved for polyneuropathy and not for cardiomyopathy, but certainly we can talk about that, yeah.
And I'll just throw in from a process standpoint, Greg. So we're aware of tafamidis. We know it's approved in Europe. At the time we started the review, we reached out to the manufacturer to see whether they could give us any information on timing of FDA submission or what have you, and we didn't really get a response. So we were flying blind, and there was really no way to include it in the scope at that point. But obviously, as things progress and if and when it becomes available in the U.S., then ICER can revisit the topic.
Stuart.
One comment and one question. Although most people know that AV block is a potential complication of untreated amyloidosis, we got to highlight that there was an increased number of AV block as potentially in the patisiran. Yeah. And so that's a topic that's complicated because it's a natural progression of the disease. My question goes back to these measures. I noticed that the trend was in the direction of better PND for the placebo arm in inotersen, and that data is not available to us. It wasn't reported, nor was the PND data reported in the New England Journal of Medicine. So I suspect you have an alternate source for those data.
Yeah.
And that would be somewhat discrepant from the improvement in the NIS score and the improvement in the quality of life if the disability score was actually potentially worse in the treated arm.
Yeah. No, I agree. I don't have a good answer for that one. I don't know. Dan or Kristen want to comment? Yeah.
I'd just like to emphasize again that those scores are really soft. So do you walk without any aid? Do you walk with 1 or 2 canes? In part, that's driven by the ambitions of the patient. And if you tell them that if they walk with 2 canes, they can't be in the trial, they all walk with 1 cane. Does that mean that they are that much better? No, clearly not. So it's really their objectives. And it's not a measure that is sufficiently sensitive with either scale to actually capture change in neurologic function, particularly over a year or a year and a half.
May I comment? If I can reinforce what Professor Burke just said, the use of the NIS scales in clinical trials is very useful because they're dynamic and they move in and out in a much shorter time frame than anything else we have. I think the disability scores suffer from the issue that John just talked about, is that they're not very dynamic and they're not very precise.
And I would just add from the patient's perspective, a 10 to 20 point change on the MNIS +7 is a huge impact on their overall quality of life. It's a patient's ability to interact with their family members the way they normally would, to interact socially, to leave the home, and so they do have incredible clinical significance to the patients themselves.
The panel is looking for some understandable effect of the drug and reasonably looking at neurologic measures for that evidence. Quality of life, however, is closely aligned to neurologic function. If you're losing neurologic function, your quality of life is going down. So it was a reasonable strategy for Ionis to have co-primary endpoints. Essentially, they are duplicate. And that experience, I think, to some degree, validates the usefulness of the quality of life to reflect the magnitude of neurologic change.
Yep. Oh, Tim, sorry.
So, yeah, I'm struggling with that a little bit. And would you advise, I guess, using the quality of life over the NIS scores as a contextual, how are these folks doing? Because on one hand, I hear you say the NIS scales don't help us very much. And if that's the case, what do we got to go on?
Well, we're looking for context here. The NIS actually is the most sensitive measure, comprehensive, to actually capture change in neurologic function. But the difficulty is it's not something that's part of our language. And so it's hard to understand exactly what the impact is. Quality of life is indisputable. And clearly these drugs have a profound effect on quality of life. I assure you that that absolutely reflects change in neurologic function. You look at the placebo group and their quality of life is headed downhill.
So then maybe two aspects of that. One, we could, instead of just showing the mean difference, prescribe it as a percent change of what their baseline score was. Because let's say the QOL started at 48 or 49. It'd be nice to get some context of what that means. Is a 48, pretty good quality of life, bad quality of life, or whatever, and then show that difference in that. Might be another way to say, well, there's a 25% relative difference, and then we can grab our hands around that.
I believe the normative baseline is 40, so above 40 is clearly altered quality of life, and actually that increment of 8 points is considered a significant change in decrement in quality of life.
There are relatively large percentage of the patients that are FAP stage 1 in both trials, approximately 50%, I mean, give or take a bit. Is there any clinical experience or is there actual experience on a subgroup analysis that would suggest the performance of the product with people that are FAP stage 1 is different than people that are at a different stage?
If you look at the supplemental data for both studies, you'll see a forest plot analysis that shows that they're fairly closely aligned, stage 1 and 2, but in one study it appeared, and I think that was patisiran, the FAP stage 2 people, so more advanced,
yep.
Actually responded more greatly to drug than did stage 1.
In stage 1, okay.
So I told Stacy I would shut up the second half. I failed again. So, were patients was there a placebo run-in or some version of run-in phase? Was some way to kind of enrich the population that would be responders with this? And 2, reflecting back of kind of the metrics for benefit we used in the morning session versus what we see here, unless we can really grab our hands around what is a clinically meaningful improvement, I was surprised to see B pluses and C pluses when you led with a we don't know what the change in scale scores mean.
Okay, so to answer your first question, I don't recall there being a run-in of placebo. And so I guess the question is, why didn't we rate these drugs lower? And I really think it's because there's really nothing else that's been approved. And we did see improvement, even though we can't say it's clinically significant. We did see improvement across multiple measures with patisiran.
I think that rather than that, though, the rating really revolved around the multiplicity of measures in which we saw benefit. So with the caveats around FAP and P&D stage aside, we saw a change there on the positive side for patisiran. And remember that a comparable or better rating relates to a possibility where there may be outcomes that we can't say anything definitive about, but that there is the possibility at least that the measures where improvement was seen or where benefit over placebo was seen would translate into clinically meaningful improvements. So
maybe you can shed some light on this for me. So I view this in a very simple way as a progressive, debilitating disease. So when we use the word improvement, I'm not expecting any improvement. I'm framing this as flat is great. And so I guess help me understand when we use the word improvement, when you say that we've seen improvement, do you mean we have seen improvement in quality of life? That is, the score goes down? Or in some other measure. Help me understand this, somebody.
Well, I think it's with inotersen, it's flat, which is good. And with patisiran, it's actually getting better because the figures are going down.
That's a very insightful comment.
Yeah.
And the objective here was to slow or stop disease. In the prior studies with diflunisal and tafamidis, TTR protein stabilizers, there is no comment of improvement because those drugs cannot achieve that. This is a quantum leap up. The struggle the panel's having is that the profound effect of these drugs is superseding experience with a scale that can capture the full effect of that drug. It's not that these drugs don't have effect. These are wonder bread drugs. But I understand the struggle of the panel. It's just grasping, understanding that. And the FDA had the same issues. It's, a quantitative scale, how does that tell you something? But the 10-meter walk, the There are a whole variety of secondary measures that come a little bit closer to the reality that you're looking for. And again, I don't want to reiterate too much, but the quality of life ultimately is the essence of treating a neurologic disease. Improvement is anything, unfortunately, it's the wrong word. A good outcome is anything that's better than the placebo group. And improvement is a declining neurologic score relative to baseline.
Okay.
That's improvement. It has never been part of the conversation. Now with inotersen, it's 36% of the group, and with patisiran, it's 56% of the group. That is completely different language.
Let me give you a chance in 1 second, Dustin. I just want to kind of restate what I was trying to state earlier, which is that, so we see, as Karen noted on the graphs, you see the trend, the stabilization trend with inotersen and the improvement trend with patisiran. The B plus and the C plus really represent our uncertainty around whether those differences are small or substantial, not whether they're there in the first place. So that's really where the evidence rating is coming from.
So let me give you my definition of improvement, because I think I totally understand what you're saying. So at 42 years old with 4 boys, they want to try to drown me in the pool while we're wrestling. I know tomorrow my hands will hurt. I will not be able to pull my belt tight around my waist for the better part of a few days or a few weeks, depending on how much my oldest son is involved in the wrestling or not, right? But that's an outcome I can live with versus the inability to use my hands at all to ever go play golf with my sons again. So if it stops there and it doesn't progress to what I know and have seen the natural progression go through in 4 generations of my family, my quality of life has much improved over my father's quality of life and what he experienced. So I think it's not, to me, it's not, well, hey, my hands aren't ever going to hurt anymore. The fact that they're not going to get worse, to me, is absolute improvement from what the given outcome would be had there not been the introduction of a drug to stop it.
And I would just add, we've done a recent study. There was a combination survey study of patients and caregivers, as well as structured focus groups and interviews with patients and caregivers. And the number one outcome that we heard from them that was significant to them was the ability to stabilize the disease and slow it, to stop it where it is, and so that they're not going where they've seen their parents go and their loved ones go in the future. That's really the most important thing.
If I may give a bit of historical context, we have a 20-year experience with liver transplant for this disease. And in fact, what liver transplant does is to stabilize the disease. It enhances survival, but people don't get better. And it is this sort of stabilization and life extension that can be achieved that way. And so if you want to use that as a surrogate for stopping progression of the disease, it's not unreasonable, but we just don't have those data that far out for either the small molecules or the oligonucleotides.
That's excellent. I think we want to move now, if we don't mind, to the economic analysis. We can catch Greg and Stacy's other comments after the cost effectiveness analysis. So Jeffrey, welcome to the microphone. Thank you.
Good afternoon, everyone. My name's Jeffrey Hotch, and I'm a professor of health economics at the University of California at Davis. And it's my pleasure to present to you today the cost-effectiveness analysis. This work is joint work. It involves an international team of people from the UK, from Canada, the US, and I'd also like to acknowledge the assistance of ICER. So the purpose of this analysis is to conduct a cost-effectiveness analysis comparing inotersen to best supportive care and to compare patisiran to best supportive care. At the end, you'll have estimates of the extra cost, you'll have estimates of the extra qualities, and you'll have estimates of a ratio. That's the purpose of this analysis. The people who are going to be going through the analysis will look like the people that were in the trials. And just like the trials have different populations It's necessary for us to have different models because the people were different in the trials. This is why we're comparing inotersen to best supportive care in one analysis and patisiran to best supportive care in a second analysis. The model itself is pretty generic. It's pretty familiar to you. It's a Markov model, United States healthcare costs. There's also a societal perspective. It's a lifetime model with a 3% discount rate. The cycle length is 1 month, and the main outcome is going to be the extra cost divided by the extra QALYs. As Dr. Lasser mentioned previously, we have different populations in the two different trials. In the trial for inotersen, you can see there was a group that was slightly younger. 2/3 of the patients were in FAP stage 1. Also, we weren't able to ascertain how many of that population had severe cardiac involvement, and as a result, we assumed it was about 14%. This was based on a proportionality assumption. Now, this is different from the group that's going to be entering the patisiran model. It's going to look like the people who were in the patisiran trial. Those people were a little bit older, and more than 50% were in stage 2 compared to 2/3 in stage 1. So the model that we built started with the structure of a previous model that was built in the UK. The previous model in the UK had structure such that there was FAP stage 1 and 2 and 3, and everyone progressed just in one way. We started to make additions to this model. To begin with, we added the possibility that people could improve, and by improve, we mean travel from either stage 3 to stage 2 or 2 to 1. The possibility is there. The second difference, the second change that we made was we started to consider people with severe cardiac involvement. These are people who have a very high NT-proBNP score, over 3,000. We decided to create this separate part of that structure because we needed a way of capturing the fact that people with these characteristics had higher costs, lower quality of life, and a greater chance of mortality. So this is why there's a separate part of the model over on that side. Initially, when we built this model, we needed to find a way to get people transitioning. So what we did is we went to the data that were available in the studies, which was P&D distribution. We could then map that to FAP, and then we had a way of transiting people through the different states. You can notice that these two are not connected. And in our base case analysis, we don't have a way of curing you of having NT-proBNP over 3,000. You can't transition out of that. But in a subsequent scenario analysis, we did test the possibility that people could improve, by which I mean people could have their NT-proBNP score fall below 3,000. And the reason that's important is because if you're in this side, you have higher costs, lower quality of life, and a greater chance of mortality. There are several other key assumptions that we made. One was that patients do not undergo liver transplantation. And we had a lot of discussion about this. There are concerns about its infrequent use and its unclear long-term impact. There was also the issue that when we looked, as Dr. Burke was talking about, the distribution of the FAP, there didn't seem to be a lot of change happening. People didn't seem to be transitioning. But if you looked at the quality of life outcome, you could see differences. So how is it possible that people aren't transitioning in terms of whether you get new treatment or usual care? If there's not a difference in transition there, how could you see a difference in quality of life? And this made us start to think perhaps we should give a benefit, a bonus, to new treatment. So even if two people were in the same FAP stage, the one that was getting new treatment would have a bump in quality of life. And this would be congruent with when you see increases in or improvements in Norfolk quality of life between the two groups. So this is why we hardwired in a benefit for the drug. Last but not least, we also assume that patients stay on treatment until drug discontinuation, either through death or they stop taking the drug, and this rate matched the rate in the trials. In terms of key cost parameters, we assumed that the new drugs would cost $345,000 a year. The first estimate seemed reasonable for patisiran because in the news release it said $345,000. And for inotersen, we made that assumption because it was our best guess in terms of net expected price. We also put in other costs as well. For getting the shot drug, we put in a training visit. And for the IV drug, we took into account the markup, the administration costs and the pre-infusion drugs. There were other costs we included as well in terms of healthcare costs, and there were costs as well related to caregiving, which you will see in the societal perspective. In terms of quality of life, this is a bad disease, and you can see this reflected in the low utility quality of life weights. The first two come directly from the trial data. When the trial data reported that the average for FAP stage 1 utility was 0.71, we chose to use that as our base case. Also, the trial reported that for FAP stage 2, the quality of life was 0.57. This is on a scale from 0 to 1. This is a bad disease. There weren't any reports that we could find in the trial of FAP stage 3. So instead, we went back to that previous analysis from the UK and used an estimate of 0.17. This is a very low quality of life. There are some other modifications we made as well. Remember I had talked about severe cardiac involvement? If you had that, then you had 10% of that utility you see here deducted off. In addition to which, if you were taking one of the new treatments, you then received a bonus. So the bonus depended on what stage you were at and which drug you were taking, and the bonus could range anywhere from 0.04 to 0.14. So these were the utilities or the quality of life measurements that we used. We also kept track of mortality, and we had it factor into our model in 3 ways. There was the natural age-specific death rate that came from the US life tables. There were also FAP stage-specific death rates. So the death rate in stage 3 would be greater than the death rate in 2, which would be greater than in 1. In addition to which, there was a severe cardiac involvement death rate as well that made it even more severe to be in that stage. After having talked to you about some of our inputs, I'd now like to share with you some of these results. The model estimates that from the healthcare sector perspective, inotersen has a total cost of about $1.5 million, compared to about $330,000 for best supportive care. If you look at the quality adjusted life years, you can see an estimate of about 4.5 for inotersen and about 3.86 for best supportive care. Now, to do the cost effectiveness analysis, you're going to difference the two and ask what is the extra we're getting. So the extra cost will be about $1.1 million to get you about 0.68 extra qualies. So if you buy 0.68 qualies at about $1.1 million, you are purchasing in a whole quali at about $1.7 million per quali. We looked at some of the uncertainty. We said, what variables, when they vary, seem to affect our results the most? So where you see the very long bars, that is where the results are being affected the most. At the top, you can see the cost of the drug. If you make the drug only 10% as expensive as it was, then you can get an incremental cost effectiveness ratio right around here. If you raise the drug price to 110%, you can get a cost effectiveness ratio right up there. So it seems that the cost effectiveness is affected by the drug's cost. There are also other variables we varied as well. The hazard rate for progression on the drug seemed to matter a lot. So if you can slow down progression, this has a remarkable effect on cost effectiveness. We took a look at this transition away from the NT-proBNP 3000. You can see that as the third one here. It does seem to have some impact, but you're still above $1 million per quali. Remember I told you I didn't know what the FAP stage 3 utility was? You can see by varying it, there doesn't seem to be a whole lot of change there. So although we don't know it, it doesn't seem to impact the results that much. So these were the results for inotersen. Let's take a look at the results for patisiran. The expected total cost is about $3.1 million. According to our model, best supportive care is about $310,000. If you look at the quality adjusted life years, the model estimates 6.54 quality adjusted life years compared to 3.11. So cost effectiveness analysis is about estimating the differences, and the extra you're going to pay with patisiran according to the model is $2.8 million. The extra you're going to get is about 3.4 extra qualies. If you're asking yourself, well, how much extra for one more quali? You divide one by the other and get about $835,000 $8 per extra quality. Again, we varied the variables to see how that would affect our cost effectiveness results. At the top, you can see the drug cost. If the drug is only 10% as expensive, it's right here. If you boost the drug price to 110%, it's over there. The long bar means the drug price really affects the cost effectiveness. You can also see the impact again on the clinical variables. The stage 3 utility, which we didn't know, also seems to have only a little bit of an effect. We did what's called scenario analysis, where we varied a whole bunch of things. And we said, what if our utilities were like the utilities for quality of life in the UK model? What if we used the British ones? Well, that would actually increase the extra cost for one more quality. We said, well, what if we use the worst utilities reported in the literature? What would that do? That also increased the extra cost per quality. We said, well, what if we didn't give the new treatments that bonus? Remember the two people in the same FAP stage? The one that's getting the new treatment gets more quality of life? What if we took that away? What would happen? Well, that really increases the cost per quality. And then we started to look at the healthcare costs. What if we doubled them? What if we were totally wrong about our estimates and we doubled every single one? If you double them, there's a slight increase in the extra cost per extra quality. What if you did half? What if you made each one half as large? Then you could see a slight decrease. These do not seem to be affecting the cost effectiveness estimate by that much. So then we varied all of the variables at once in a probabilistic sensitivity analysis. And we said to ourselves, when we do that in terms of our beliefs about what these variables could be, what's the likelihood of cost effectiveness? Well, if you are willing to pay whatever value you see on the horizontal axis, then you can see on the vertical axis the likelihood of cost effectiveness. So hypothetically, if you are interested in paying $500,000 as your threshold, you can see the likelihood of cost effectiveness is, shall we say, below 10%. And for this drug here as well, it's also, you could say, below 10%. And this is the pattern we're seeing for both drugs. The limitations. There is a lack of relevant cost-effectiveness data, and this is how come models are so useful. It helps point out where the uncertainty matters. That's with those bars you were seeing, the horizontal bars. There's a lack of long-run clinical data, and this speaks to the role for more evidence to be collected. And there's a difference in trials, the trial populations, that makes it really difficult to compare one drug to the other. We did get some comments about our model and in the report. And one of the comments was that we should allow for benefit and quality of life even within FAP stage. And this is what we put into the model, and we allowed it to continue. It built up through time, and then we allowed it to plateau and continue for as long as people were taking the drug. There was also concern that we should consider liver transplant. And we thought about it, we talked about it, we had discussions with our experts, and in the end did not include it. We were told to explore impact on caregivers, and we did in our societal analysis. And we were told to keep the analysis of the new treatment separate, and we did. In conclusion, the estimated cost effectiveness of inotersen is not near commonly used cost effectiveness thresholds. Also, the cost effectiveness of patisiran is estimated not to be near commonly used cost effectiveness thresholds. In conclusion, I'd like you to remember, though, for treatments for ultra-rare diseases, policymakers often consider other benefits and contextual considerations that may lead to funding at higher cost-effectiveness thresholds.
Actually, Jill, before you start, can I just want to throw a couple things into this?
Stan's going to chime in.
Sorry. Realize we never answered your question. So the PND stage change data for inotersen comes from a dossier the company submitted to the Center for Human Medicinal Products evaluating the drug for the EMA. So that's a public report, and so we use that information from there. I believe the PND stage change data for patisiran comes from a poster presentation that was publicly available. Jeff, one thing that you might want to mention is what the impact was of the societal analysis, whether and how the results differed.
Okay, so the societal results are going to include the costs that will also be occurring to the caregivers as well as the patient themselves. This had the result of slightly increasing the incremental cost effectiveness ratio. It wasn't a huge bit different, but it was slightly larger. So if you're keeping people alive who have a disease that is bad quality of life and expensive for their caregivers, then if you keep them alive a little longer, it's going to look a little bit more expensive, and the extra quality of life may not be as large because you're going to have caregivers who are also going to be suffering quality of life losses. It wasn't a giant amount different, and for that reason, it's in the report, all of these analyses, but we chose not to go into it in detail with this analysis.
Well, on that sad thought, Jill.
So without a minimal clinically important difference in some of the measures that they did, how do you assign a utility to that?
Yeah, this is a really good question. So you have, I'm going to just pay you the compliment of being blunt. You have data on things that might matter in one setting, but in a health economics setting, what we want is a difference in quality adjusted life years. There's two ways to get that. Either they decide in the trial to measure it, in which case you'll have it, or you have to find a crosswalk. You have to sort of say, is there one way to map one to the other? In the earlier York report, there was a study where they mapped the data that we have to the data that we want. And we used that crosswalk to then take the scores and map to what we needed. And we also did sensitivity analysis in case we got it wrong to see what impact it would have.
Good. Harold? Microphone, please. Sorry.
I'm sorry. I was looking at that 0.17 quality of life assessment for state. That's really quite low.
Yes.
I don't know that I've seen in very many analyses a number that low for almost any condition. Can you? I know you did some sensitivity analysis around it. Can you explain how much you varied in the sensitivity analysis? Because I just wasn't exactly sure from the diagram. And B, can you explain why you gave such a low number for that, and talk a little bit about that?
Yeah, so this is really good. So we're talking about how bad is that state of life. 0 is dead. 1 is perfect health. And the question is, if you think that stage 3 is worse than stage 2, then what should it be? It's probably lower than 0.57, and you gotta hope it's more than 0. So the question is, where through there? The York report, the one I was talking about earlier in the UK, I believe they used about 3.7. So in that scenario analysis where we go ahead and we say, what would happen if we actually used the York model utilities? What we end up finding is actually a higher cost per quality. The reason we chose the 0.17 is we took one of the equations that they had, one of the crosswalk equations that they had, and attempted to model with that. And we wanted to reflect how bad a state that was. I wonder if the panel has anything else they'd like to add.
I think we'd love to hear from the clinical experts on recognizing the FAP stage 3 as a blunt instrument. What is life like for the patient and their families in that stage?
It's terrible. I mean, in a sense, this is a disease that almost mimics ALS. I mean, people are completely reduced to being bedbound, unable to defecate without help. They may not be able to urinate at all because their bladder doesn't work. They can't sit up because their nervous system doesn't support their blood pressure. I mean, it's bad. Their GI tract completely is useless. They either have profound diarrhea or overwhelming constipation. It's really a bad disease. Dr. Hodge, I thought your analysis was really elegant. The difficulty is exactly what you've asked, and that is, how do you assess a quality measure that will translate? And you don't have that. So without being able to understand how dramatic the effect of these drugs is, you can't do an analysis that has real meaning from my estimation. I'm not interested in the cost of these drugs. I'm interested in the drugs and the patients. But it comes, I mean, from my point of view, instead of adopting less and less sensitive measures that can detect change neurologically, going from PND, which has 4 stages, to one that has 3 stages, where you recognize that there can be quality of life changes within a stage, and that seems contradictory. What it's telling you is you're using the wrong measures. If you simply used quality of life measures, I think you'd be closer to it, and I'd be interested in how that analysis might come out. But despite the sophistication of the analysis here and the modeling, the basic weakness is having a measure that you all can grasp as, reflecting the benefit of the drug, and you don't have that. You haven't incorporated that into this model.
Is that because the model has failed to include available quality of life instruments, or is it because?
Well, if you used a quality of life instrument, it would be sort of as a surrogate for a direct neurologic measure. Right. But it comes a lot closer to demonstrating the impact of the drug on life. And ultimately, I think that's what the analysis is meant to do.
So I just want to interject here that these utilities, these quality of life weights, come from the data from the trial. So we have the Norfolk quality of life, and the problem with that is that it's not a quality of life utility. It's something that people believe in if they do the disease, but if you're doing health economics modeling, you want a quality adjusted life here, and to make that you need what's in this column. You need a utility value. So we've got this and this from the people in the trial. We're just missing that one there. We got that one by trying to take that crosswalk from the quality of life measure and then map it over to the utility.
Yeah, I actually understood methodologically what you did, but it just seems to me I would hate to see, it just seems to me that that's so
really low, yeah.
That like I wonder with ALS what the comparable numbers would be, for example, in an analysis like this if we were doing ALS. And just if you could say a little bit about the sensitivity analysis that you did around that 0.17, I'd appreciate it.
It's also important to recall, Harold, that there were few to no patients starting out in stage 3 in these trials and very little transition into it.
Oh, okay, so then that answers the question. Okay.
Right, and the stage 3 utility that Jeff varied also had very limited impact on the results.
And it varied, what was the range?
By 30%.
30% of
Up and down.
0.17 or 30%?
Of 0.17.
So that's it's like from 12% to 22 or something.
Yes.
Okay,
yes.
Thank you.
Oh, Reem, I'm sorry.
It's a comment versus a question. I just want to highlight, I think the issue here is the way the outcomes have been measured in the studies. And this is what we have. And we just have to deal with the lack of good measure that we're dealing with. So when we say we or you, it's really whoever published the study. And then it's on the patients groups and the experts to require better discriminatory measures that can distinguish the true effects. But currently, I'm just thinking, I can't think of suggestions for your model to say, okay, here's what you can, giving the limitation of the data we have, you probably should have done this. I think the fact that you went into giving bonuses within the same, stages, I can't think of something else to ask you to do in the model. It's the limited data that we have to deal with.
I just want to also interject that, and Jeff probably was going to say the same thing, so he's already reinforced the fact that the stage 1 and stage 2 utility data come from the trial. That bonus within FAP stage comes from the Norfolk QOL data from the trials. So these are trial-based estimates, both within stage and between stages.
Ryan? Oh, no, I'm sorry. Go ahead.
Does the model include enhanced survival?
What do you mean by enhanced survival?
By saying that, okay, if you stabilize neurologic progression, you can in fact increase survival by 10 to 15 years.
What the model does is it keeps track of which stage you're in. And because you have a better chance of living if you're in a lower number stage, if we can keep you in stage 2 instead of stage 3, you will get a benefit. But it's coming because you're in that stage.
Now, only because that, again, you did not include the liver transplant data. But the liver transplant data clearly shows that if you arrest progression of the neurologic disease, you enhance survival considerably. And those data are becoming better and better, and there's a recent paper out that does an even more precise analysis. So it would be, I just wondered whether that kind of observation from an independent source impacts on the estimates made from this model.
I'm not sure what your question is.
The question is, if the data we have that say you don't progress give you 10 years of extra life at that stage, how do you measure that in this model?
Okay, so the different places where you can hang out are stage 1, stage 2, stage 3, and you can be hanging out there either with or without severe cardiac impairment. So the challenge is to keep track of the people and where they are in the stages. So if it's possible to create a treatment that keeps people in stage 2, they won't have to incur the higher costs, the lower quality of life, or the greater chance of mortality that comes from stage 3. Now, how did we get the numbers to know where the people were? We took that from the trial data.
FAP and P&D scores were reported in the clinical trials, not because they were thought to be accurate measures of change in neurologic function, but just sort of almost for historical context, so that people had some idea of what we were dealing with. But you can have improvement or significant decrement in neurologic function within any stage, and the quality of life will show you exactly how much of that is occurring. So the model is using measures that aren't sensitive enough to reflect what you're really after.
And this is why we tried to include that bonus from the within stage.
Of life, but despite the bluntness of the instrument used to track just survival, in the report, undiscounted, and the 3% discounting not being used, that as is typically used in modeling, a 70% increase in life expectancy with patisiran versus best supportive care. So 12.3 versus 7.4 years based on the starting age. So about a 65 or 70% improvement in life expectancy. Smaller improvement with inotersen, again, based on the stage change data we had available to us, but a survival benefit is being modeled here. It's not just quality of life.
I just want to add the comment about the tools, the quality of life questionnaire that was used. The Norfolk Quality of Life, it's a diabetic neuropathy scale. It was developed, validated for diabetes. I feel like the fact that it actually showed statistically significant differences in this patient population is huge. And I think what we see between the NIS plus 7, the MNIS plus 7, the Norfolk Quality of Life data is these treatments do have an impact on the underlying disease. And these patients experience a very wide range of symptoms. And so the fact that we're seeing difference on the Norfolk and the NIS, I think, is really indicative of what it could be doing across the broader disease. These trials were designed 5 years ago, more than 5 years ago. There was very little natural history date prior to that. So I think there will be, for future next generation drugs, there will be a lot of work to do to develop better and more comprehensive tools that really capture the broad spectrum of the disease.
Ryan, you want to
just
take us home?
Can you go to slide 40, your assumptions?
Slide 40.
So can you explain the bump, the second bullet?
Yes.
Is that like is it like a placebo? Like I'm on a new treatment, so and I know I'm on a new treatment, so I feel better? Is it kind of like a placebo effect?
No, that's like we really, really wish that people in the same stage would have the same costs, the same qualities, the same everything. Unfortunately, what we're hearing from clinical experts is that the thing we're using to stage doesn't do a great job, and there's a lot of heterogeneity. And they actually
within a given stage.
Within a given stage,
Okay.
and they even know the direction. They're willing to tell us that the people in the stage who take the new drug actually are going to do better than the people in the same stage who are not taking the new drug. So not only is there heterogeneity, there's also, it's kind of organized. So then the question is, how much bonus do we give? In a perfect world, they wouldn't have the same stage. But because we got them in the same stage, we need to somehow benefit new treatment. And then we take a look at the Norfolk quality of life and try to convert it to QALYs.
Benefit a new treatment because of the heterogeneity within the stage.
Benefit because the new treatment is working, and we're not giving it credit for working in the gross model that we've used. If it
So I guess I'm struggling with the term bonus. It's giving, so within a stage, it's giving higher for folks that are on the new treatment that are actually experiencing changes in
Yes.
quality of life.
Yes.
Okay.
The question is, when you see that gain in Norfolk quality of life, how much should that be in terms of utility quality of life?
So that is giving points, whatever,
Yes.
to changes in the quality of life score.
Yes.
Okay.
Not
Okay.
because it's
So
a placebo.
It's not a placebo. Okay.
Good point.
Excellent. Thank you very much. It was a spectacular presentation. You made a difficult topic very clear to many of us. Thank you very much. We're going to move on now to some comments from patient groups and our industry partners. But we're going to start with Muriel Finkel. Is she here? Hi, Muriel.